Good morning.
Sorry, it was yours. I have read it.
No disclosures. So little is known about the real long-term functional quality and complication rate of long-existing urinary deviations, even though it's very valuable to know for patient counseling. So what we did is we conducted a retrospective study on 43 patients who had their urinary deviations constructed at least 25 years earlier. We ended up with a mean follow-up of 40 years, which is 4 times as long as now known in literature. We looked at the total group, but also separately analyzed it for disease origins and deviation types. We looked at the following endpoints. Starting with the surgical re-interventions, we found in the total follow-up of 40 years a mean number per person of 4, implying 1 intervention per 10 years. We also looked at the time to the first surgical re-intervention, being a mean of 14 years, with some patients operated within the year and others being 60 years of surgery-free. And if we look at the reason for surgery, it was mainly because of urinary tract stones, followed by stenosis of the urethroileal anastomosis and peristomal hernia. If we separately analyze this for deviation types, we can see that the urethrosigmostomy is superior to the ileochondrite, both on number of re-intervention, but also on the time to the first surgical re-interventions. You can see that they have 4 times less surgical re-intervention, and that it almost took 20 years longer before the first surgery was done. If we look at the reason for surgery in these 2 groups, we can see that urinary tract stones are common in both, and that the others are mainly because of deviation-dependent complications. In the urethrosigmostomy group, we found 1 patient who had their urethrosigmostomy converted into an ileochondrite because of an adenocarcinoma of the colon. Often is stated that urinary deviations constructed for benign reasons, for functional reasons, are more cumbersome and more prone to complications. If we examine this in our series, we can see that the number of re-intervention is similar, which is 1 per 10 years. But the reason of surgical re-intervention did differ. Whereas for oncological reason, it was mainly because of urinary tract stones. You can see that for the functional group, the complications were more difficult to treat and needed more invasive surgeries, such as the peristomal hernia or leakage. Other endpoints we looked at was hospitalization. 2/3 of the study population was at least admitted to the hospital once, mainly because of urinary tract infection, whereas there was a mild kidney function deterioration going from creatinine level of 88 to 114. And at the end, 45% of the patients still had a GFR above 60. We did see that urinary tract infection, chronic or apparent, were very common. 95% of the study population had to deal with this. So in conclusion, we can say that the clinical benefit of our study is that you could say it's possible to live and cope with urinary deviation with only 1 intervention per 10 years because of the malfunctioning. Surprisingly, the urethrosigmostomy gave very well results, which might open doors again for treating bladder exstrophy, or at least underlines the proper functioning as a treatment for bladder exstrophy. But also the ileochondrites can be constructed with proper functioning and an acceptable complication rate. So the deviations constructed for functional reasons do not have more re-interventions, but they do have more cumbersome and difficult to treat complication comparing to the oncological group. Thank you.
Thank you very much. Are there any questions from the audience?
Hi, thank you for this presentation. Were there any urethrosigmoidostomies that were converted to an ileochondrite, so that you have a bias and you're looking at the best urethrosigmoidostomies?
Yeah, quite amount. 45% had a mean of 40 years diverted into a ileochondrite, but the complications were calculated, like to the time to the urethrosigmostomy, the complications, and when they became a bigger ileochondrite, we calculated with them. And it was mainly because of recurrent infections or anal incontinence. So that does, yeah.
But there might be a bias because there was some conversion of one deviation to the other.
Yeah, Yeah, that's true. Yeah.
I want to ask you about the renal follow-up, the nephrological follow-up, because you're using serum creatinine, and obviously with a mean serum creatinine of 114, the estimated GFR can be as low as 50 or 60. Mm-hmm. So I think nephrologists would always say creatinine is a poor measure compared with GFR.
But yeah, unfortunately, going back into the patient files, there were no GFR only after a certain amount of time, and we found earlier creatinine levels. So to kind of show a trend, we used the creatinine, and then at the end point, we could say, well, we see a GFR of this, but it's unfortunate that we couldn't.
So do you have your patients under joint nephrological follow-up as well, the ones who have a poor GFR?
I have to. We don't. Sorry, I had to ask my supervisor. No.
Well, I can recommend a joint uronephrological clinic. It's extremely useful, and these sort of patients get much better care from nephrologists than they do from me. Yeah, so I think it's probably best practice to do that. Needed.
So it was quite well with the kidney function. And normally, when they have a bad function, we will send them over. So they're not regularly with a nephrologist. And these people are only with ourselves.
The thing the nephrologist will say is that they can reduce the rate of deterioration in a way that,
is it needed?
By controlling blood pressure, infection, etc., etc. So I think they do. We've found them extremely useful.
Yeah. Now we have general practitioners in the Netherlands, so they can check for the blood pressure and other things. So that doesn't need to be done by the nephrologist, and they only will be sent over when there are problems.
I mean, that's your opinion.
Okay. So another question there.
In the 1980s, there was a big trend towards undiverting, particularly conduits done for functional reasons in exstrophy and spina bifida. And the concern was based on fairly solid evidence at the time that ultimately conduits led to a deterioration in renal function if you followed them for long enough. I mean, this is evidence that goes against that, but it certainly informed a long period of practice where that was not considered to be optimal for the management, particularly of kids who are going to be living for 30 or 40 years. Are you confident that this now overturns that evidence? That mostly came out of Toronto, the evidence that they aren't good ultimately for renal function.
I think because the number of patients we now research was 43, which is not the biggest group I would suggest further research and like a multi-center analyze to kind of build up your power and build up the number to see if there's a difference in that, and then you can discuss it again. I think it's maybe a bit overdone to base it purely on these results we have right now.
Small comment from my side. Perhaps I should refrain from comment because I think I'm responsible for some of these diversions in the years that I was working in Nijmegen. But I think the second statement is quite controversial. Opens the door for uterosigmoidoscopy. And you base that on your results, but it's only a small fraction of the patients. And having seen personally so many major problems on long-term follow-up with uterosigmoidoscopy, I would be very careful in not stating the second statement too strongly.
Good point.
You agree?
Yes. Yeah, I agree.
Thank you.
Thank you.
Thank you. We move on. Thank you.